Pathology Part 3. Today, we are having a lecture on cell counter flags and slide review criteria by Dr. Anil Handu, who is currently the Principal Director and Head of Department Laboratory Services, BLK Max Hospital, Delhi. Chairing this session is Dr. Kunal Sehgal, who is the Director of Sehgal Path Labs, Mumbai. Dr. Priyavadna and myself, Dr. Diksha, we will be moderating this session for you. And the webinar hosts are Dr. Anita Borges and Dr. Sumeet Gujral. These are some reminders and usual disclaimers. There are two upcoming talks. On 21st March, we have a slide seminar on approach to pancytopenia by Dr. Manupdesh Singh Sachdeva from PGI Chandigarh. And on 26th March, we have a lecture by Dr. Sukesh Nair on newer parameters in cell-based counters. Without further ado, we'll start the lecture.
Good evening, everyone. At the outset, I would like to thank Dr. Gujral and rest of the team for Center for Oncopathology for giving me this opportunity yet again to talk about hematology, cell counters, flags, and slide review criteria. I bring you warm regards from the Institute of Laboratory Medicine, Dr. B.L. Kapoor Memorial Hospital, New Delhi. And of course, acknowledgement to my lovely team back home, who give me this opportunity to ensure that the data that's derived from our work is presented to people around the world. So let's get going. This is how I have defined my talk today. We'll be talking about a few historical aspects. We'll talk about concepts of flagging. We'll discuss slide review rules or slide review criteria that they are usually called. We'll talk about the concepts of validation of slide review rules, and we will also talk about automated selection and release of reports. So let's take a quick peek into the history, and we will just go through a few questions to know where we stand as far as hematology analyzer practice is concerned. So the first question is, cell counters are based on one or more of the following principles except. The answers are either impedance, light scatter, sonology, and image analysis. And the answer is sonology. Obviously, we know that most of our cell counters are either based on impedance or light scatter or a combination of both. And in today's day and age, we also have some analyzers which are based out of image analysis. The next question is that all of the following possess patents related to hematology cell counters except. So you have Wallace Coulter, Joseph Coulter, E. A. Epstein, and Paul Ehrlich. And of course, the answer is Paul Ehrlich. We know that Wallace Coulter and Joseph Coulter were the Coulter brothers, the so-called Coulter brothers, who actually gave us the concept of Coulter principle. And E. A. Epstein was one of the people who actually gave us the concept of flow cytometry many years ago. And it was Paul Ehrlich who basically talked about stains. So obviously, Paul Ehrlich is the exception in this answer. So if we look at hematology automation today, it is primarily based on two general principles: electric impedance or electronic resistance and light scatter properties. The primary principle of cell counting is based on what is called the Coulter principle. And if you look at Coulter principle, the expected Coulter principle is that we have a chamber or an area where there is isotonic solution present, and we are letting the current pass through an aperture between two positive and negative electrodes. And as we know, the cells, when they pass through this aperture, they are poor conductors of electricity, and they'll stop the passage of current or impede the current passing through. And that in turn will help us to count the numbers. And depending upon the size of the cell or the particle which passes through this aperture, it will give us a variable amplitude. So in effect, it will also give us what is called the relative size. So let's quickly look at the journey of a sample of blood which goes through a CBC in any hematology analyzer for that matter today. The blood gets passed into two distinct channels. One, which is what is called the RBC channel, RBC and platelet channel, which is generally where you have the RBCs which go in for dilution, and post dilution you're actually able to get your hemoglobin if you're passing it through the hemoglobin chamber, and you're also able to get your counts. And this all these counts are primarily based on the impedance part of it. You also have a second part of it which goes into the WBC chamber, wherein you have variable methodologies of, staining the WBCs or not staining them at all, and then making them go through either the impedance channel or a combination of impedance as well as fluorescence channel, and you're able to get your data out, which eventually the analog data gets converted into digital signal, and you're able to figure out what you're on the hematology analyzer to figure out what you're dealing with. So as I just mentioned a slide ago, electronic resistance or impedance basically is based on the fact that the blood cells are non-conductive for electrical current. And as the blood will pass through the orifice of the chamber, it will impede the passage of the current. The resistance between the electrodes will get increased, and depending upon the relative size, an electrical pulse will be generated, which will then define as to how many pulses came in. Depending upon the number of pulses, you are able to count the number of cells, and at the same time, depending upon the volume of the pulse, you are able to generate what size of the cell had actually passed through. More importantly, there is also something called hydrodynamic focusing, which allows the cells to pass in a single line so that we don't have recurring events coming for counting. Now, this is a pictorial representation. As you can see, every time the cell passes through this aperture, there is an impulse which is generated. A pulse that gets generated multiple number of times is able to give you relative counts. It's also able, the amplitude of the pulse is also able to give you the relative size of the cell or the particle that passes through. There's also a very interesting story about the way the entire concept of impedance counting or Coulter principle came about. And the picture lies in these three things in front of you. One is the cigarette pack, which has this parchment paper. You have this thread and the needle. And what was done was a hole was created through the parchment paper of the cigarette butt and made uniform by use of thread, and subsequently placed inside a chamber with isotonic fluid, separating the two electrodes. And then from there, the cells would pass through. And this constituted what was called the first aperture in the case of the Coulter principle. So these were the Coulter brothers in their younger days when they had looked at it as a methodology of defining how the paint would look like, and for that they actually used their own blood to decide as to how the analyzer is going to be really working. And this is a more familiar picture of the Coulter brothers, which was, which came out much little later compared to what we had seen in the past. And of course, this is the picture of Sir Wallace Coulter, which is what we are most familiar with. And in fact, Wallace Coulter, in his name, actually, there is a big time award which is also given across by International Society of Laboratory Hematology every year. And so the contribution of this man was immense with respect to hematology cell analysis. Interestingly, when Sir Wallace Coulter and his brother approached the patenting authority in US, what they were told is, come on, you cannot patent a hole. And with that opinion, he had to actually really take a help of a lot of counsels to really get a patent for what he had actually defined. It's a different story that a few years later, this actually found a way into the system of the people, and people accepted it as a part of the patenting process. Interestingly, another aspect which needs to be kept in mind, it was really not the impedance methodology which was the primary methodology to identify cell numbers or define the cells. In fact, the first methodology which was adopted was nothing but a flow cytometry in which the cells went down through a capillary tube and they were made to pass through a light beam, and then light beam actually helped them decide whether the number of cells was there, which was the kind what we were trying to look for. And interestingly, this is the gentleman who actually gave us the first cell counting methodology using the flow cytometry methodology. And this man's name was E.A. Epstein. And their patent, which was given across to them at the first instance, was for the Technicon system in which flow cytometric light scatter measuring measurement was done for the red blood cells and the hemoglobin concentration. And these are obviously those patented graphics which were then at that point of time given the patent what we are talking about. So what was the aim of having a cell counter? We were all looking at cell counting, whether we were talking about counting by impedance or counting by flow cytometry. The idea was primarily to reduce manual labor and to reduce the work of reviewing smears. But it had its own challenges. You were worried about missing a case. This is what led to the concept of what is called flagging. And flagging here was to flag an event or a sample which would have been passed through the hematology analyzer to go and check the slide for any abnormalities which would be coming. So let's look at the question of flagging in a cell counter as to what it signifies. Does it mean putting the flags to the vendor on the instrument? Does it mean that it's a methodology of alerting the user for any kind of a review, or alerting a user regarding the change of the reagents, or alerting the user of potential impending electrical short circuits? The answer is methodology of alerting the user for any kind of a review. So I'm sure by now we would have understood flagging basically means alerting the user of the hematology analyzer about a possible requirement of looking at the results from either a review of a slide or looking at it from the standpoint that it's flagged on something which is important for us to look at or delve into. Now, when we talk about flagging, what are the different kinds of flagging that we, can have from any of the analyzers that we use? The most common ones is what is called the condition flagging. Condition flagging means it will describe the normality or the abnormality of the cell populations. Then you will have what is called the suspect flags, wherein the analyzer has suspected the cell population to be falling in an area which potentially may be abnormal. For example, you might have a flag for blasts, you might have a flag for immature neutrophilic cells or immature granulocytic cells. You might have a flag for variant limbs, and most importantly, whenever you have what is called an R flag, it is nothing but a review flag. That means you will have to review a slide. Let's look at other cell-based flagging. For example, if you look at the red blood cell flagging, you can have flags for nucleated red blood cells. You can have flags for morphology of the red cell, like you might have macrocytic cells wherein the MCV itself or the cells which are falling in the higher side of the mean corpuscular volume are tagged as macrocytic RBCs. You might have flags for dimorphic population. That means you might have microcytic hypochromic cells and macrocytic cells. You might have a flag for RBC agglutination. You might have relative fragmentation or the fragmentation of red cells which you might be picking up, and that also can be picked up by the analyzer and flagged. And in addition to all of these suspect flags, you might also have what is called definitive flagging. For example, when you predefine the limits of the lab at which you would want critically to be alerted. For example, if you want a hemoglobin of less than 5 to be your critical alert, the customization of the flag can help you define that at this point, the analyzer will tell you this is critically low. It will also help you to customize your own flagging criteria for providing information for review. So all of these can be flags for specific cell population. Now, when you look at any analyzer-based flagging messages which come across, they are relatively, some of the messages are kind of common between most of the analyzers. However, there can be specific methodology of alerting the user regarding the messages or the flags which come in from an analyzer from different instruments. So getting familiar with your instrument becomes very important as far as the flagging messages are concerned. For example, the asterisk message which comes in some of the analyzers means that it's exceeding the instrument's thresholds. Plus means it's exceeding the linearity range. AL, that means it's alert low. Similarly, AH means it's alert high. CL, critically low, or CH, critically high. Important ones are, which most people do usually ignore, is the what is called partial aspiration. Some of the analyzers are actually giving you the concept of P, which means that the aspiration has not been appropriate, and therefore the results which are coming from that analyzer for that particular sample may not be appropriate. Additionally, you may also have, the alerts from the instrument to tell you about instrument functioning. For example, sometimes it may not compute properly and it might give you these dotted lines. Or sometimes there may be a complete out, or sometimes it may be going beyond an operating range. And in some cases, you might even have detection of clots. So in all of these cases, you would be expected to take appropriate remedial measures. So, interestingly, I often get asked that, we have three different choices of analyzers as to which analyzer should I opt for. For example, in this query which I was asked, I have an analyzer A in which counts are okay, but it flags nothing. There's an analyzer B in which again counts are okay, but flags too much. And analyzer C in which counts are again okay, but flags just right. Which amongst these would be the best to be used? And I'm sure most of us would obviously opt for analyzer C. But for all practical purposes, when I look at all of three analyzers, the counts seem to be okay in all the three. It's only the flagging part of it which does not seem to be following what I want it to follow. So what does this mean? I have not been able to ensure that the customization of flagging has been taken care of on the hematology analyzer, which is otherwise a requirement of us to take care of it as a user, as an end user. So this leads us to the concept of flagging setup. It's important for us to realize that when you set up your flag, the flaggings do come up with the certain thresholds which have been set up by the industry or the vendor itself. However, many a times these flags may either be set at a threshold which might not be optimal for the kind of samples or the kind of workload that you handle, or it might have been set up in such a way which is not adherence or which is not giving you the right information regarding the kind of samples that you're dealing with your lab. So therefore, customization of flagging becomes extremely important. So this brings us to the concept of optimization of flagging or setting up of flagging in your various instruments that you use in your setups. Remember, for all practical purposes, when you allow the cells to be counted in a hematology analyzer, there are certain arbitrary scales in every hematology analyzer wherein the data or the dot which is coming onto the scatter plot has a specific X, Y, and Z coordinates. And depending upon the X, Y, Z coordinates, you are able to define them at a certain standpoint and its location within the scatter plot. Now, when you define as to a particular threshold beyond which this dot plot is giving you a variable number, you are identifying that variable as a cutoff for you to flag it up as something which is not falling in the right place. For example, in Sysmex, you have what is called queue flagging system. In Minder, you have iMessaging system. And likewise, you have many other instruments having a similar kind of a concept where you have different messages coming across. For example, you look at all of these messages which are coming from the queue flag of the hematology analyzers. By default, for example, this has been set up at 100 and all of these some of these analyzers. And eventually, when you optimized it or modified it to suit your system or your analyzer or your sample load, you identified them at a much different value than the original default value. So if you look at flag from a hematology analyzer, it can either be negative flag, which means that there is no abnormality which has been detected by the hematology analyzer. It can be a positive flag, wherein one or more of the messages which is coming from the analyzer has been generated, and it can be a suspect flag or a definitive flag. And last and not the least is the most important one, which talks about error, wherein there has been some kind of a functionality issue within the analyzer which one needs to be careful about in terms of flagging. So flagging system, in other words, functions something like you know a traffic light system. For example, if you have no flags, that means it's negative for any of the flagging. After you have optimized your flagging system, mind you, then you can just directly go and report the sample. If you have a positive flag, you might want to review a smear or maybe the historical aspects of the patient's condition and then finally report the case. Or you might have an error, in which case you might either want to review or maybe rerun the sample so as to get a negative, kind of a flagging and then only report the sample for that particular patient. So as I told you, positive, you can have an abnormality which might have been identified, say, in a differential, or maybe in a morphology, or maybe in the counts. You may also have what is called an error, and that's what I already mentioned. You might have a problem within the barcode of the sample that had been used. You might have a data which might not be adequate in number. For example, severely pancytopenic samples which are falling below the linearity limits can give you an error result. Or you might have an abnormality of the delta check. That means the previous sample of the same patient, the analyzer is able to detect based on the unique identifier of the patient, and you are actually able to identify that there is a change or a marked variability in the previous and the current counts, which is otherwise called a delta check. As I said, flagging system has got lots of interpretative or IP data messages, which are either classified as frankly abnormal. That means there is a specific defined abnormality which they are picking up. And you can even set this up. For example, in a newer hematology analysis today, you are able to set up your flagging for infected red cells depending upon certain parameters. And on the other side, you have these suspect flags, which is actually able to indicate that there is a probability of some issue within the sample which needs to be taken care of. Where do we collect these interpretative data messages from, or where are they detected from? They are detected from the cellular information which is gathered either on the fluorescence or on the forward and the side scatter. You can also set them up for certain parameters. For example, as I told you about infected red blood cells, you also take information from scattergrams and some histograms. For example, the RBC histograms and the platelet histograms to identify the presence of fragmented red cells as well as large platelets. Coming to WBC flagging, you might have abnormal flagging regarding WBCs. For example, you might have a scattergram which is not falling into a classical normal kind of a pattern. You might have definitive flags like neutropenias or neutrophilia, lymphopenia, lymphocytosis, etc. Likewise for other cells. And then you will have a possibility of picking up the suspect flagging, which I already mentioned about the other cells as well. So here you will have suspect for flags, you might have suspect for immature granulocytic cells, left shift, atypical lymphocytes, variant lymphs, and some of the analyzers also have the concept of what is identifying high fluorescence cells or high fluorescence lymphocytes. There are also some analyzers where you're able to pick up what is called hematopoietic progenitor cells or the blast cells. So all of these can also be picked up on WBC platform. Coming to RBC flagging, the classical abnormal RBC flags, which are seen in majority of the instruments today, you might have an RBC abnormal distribution. For example, you can have this sometimes in conditions of cold agglutination. You can have abnormality in the reticulocyte scattergram, which can give you a possibility of picking out the fragmented red cells. You can also have what is called reticulocytosis, macrocytosis, microcytosis, etc. And all of these are definitive flags because they've been picked up very clearly and distinctly, and they've been, kind of identified by the analyzer with almost near 100% authenticity. On the other hand, you also have suspect flags on the red blood cells. For example, you have interferences of lipids. You can have interferences in the RBC counting, leading to what is called RBC agglutination. You can have iron deficiency, which may be suspect based on the analyzer, the data that's coming from the red cell indices. You can also pick up fragments, as I already mentioned, for the red blood cells. Similarly, for platelets, you have classical abnormal distribution of platelets, which can be picked up. You can have abnormalities of platelet scattergram, especially in the analyzers, which are depending on the fluorescence of the flow cytometry patterns. And then you can also have suspect flags like platelet clumps and giant platelets. So all of these are flagging, classical flagging for platelets. So I was mentioning about quantitative monitoring of flagging, and these are the pictures from the Sysmex analyzers, wherein we have the concept of looking at blasts and defining at what percentage are you actually going to be classifying as something as blasts. So here, the threshold has been put across at 100. Anything which is less than 100 will not be identified as blast, whereas anything which is going beyond 100 will definitely be identifying it as blast. What is also important to realize is that while the percentage may not be exact or truthful, you also need to remember that you will be actually able to quantify also in certain cases. So depending upon the thresholds that you're setting up, the relative quantifications can also be given across by the analyzer, which obviously will not be 100% foolproof, but at the same time will be able to alert you to know as to what is the kind of abnormality that you're dealing with. So the picture slightly on a higher kind of magnification over here. You have this IP message which is for blasts, and it's from the Sysmex hematology analyzer, wherein you have defined it at 100 threshold, and anything about 100 threshold is identified as a blast or an abnormal cell. And depending upon the trigger level, the degree of abnormality will be variable, as is seen in both of these cases. The variability in the first one is higher, the variability in the second one is lower, and therefore, if you see, depending upon the variability or the level of abnormality, you are actually classifying two distinct aspects as two different things. For example, the one on the left hand side is identifying this more as blast, while as the one which you're seeing here is more of a left shift. So that gets us to the next question regarding flagging on a cell counter. Now, cell counter flagging is defined on the counter in an administrator mode. It needs customization at the user end, and once defined and validated, needs to be applied in the sample mode, or the answer is all of the above. Obviously, in this particular case, the answer is all of the above. You do definitely need to do it in what is called an administrator mode, or the engineer who will come and help you to set it up. Once you have done it, you would want to customize it to your needs and the kind of samples that you get from your clients. And more importantly, once you have defined it or customized it, you need to make sure that you validate it appropriately to ensure that there is no too much false positive or no too much false negative, to ensure that it's applied on the sample mode as well. Thus, having it applied on the sample mode after the administrator mode is equally important. So when you're trying to define, the cutoffs for you to be alerted for various, definitive messages, for example, a high white blood cell count, or, erythrocytosis, or maybe, high hematocrit levels, or dimorphic anemia, or microcytic anemia, etc., you will have to know the linearity limits to which the instrument is capable of handling it, and beyond which only you will be able to actually determine what you are dealing with. So now let's change gears a little. I'll take you through my journey, when I was moving across in terms of my career. It was way back in 2011. We were going through our, NABL accreditation audit, which was a final audit. And at that point of time, we needed to look at what was called a slide review criteria, and that's how I'm changing gears from flagging to slide review criteria. In fact, we were interviewed by our assessor, and we were asked, how do you decide when you do a slide and how you are not when you're not going to do a slide? So we said, yes, we have kind of defined it amongst ourselves that this is the time when we will do it, and this is the time we will not. The question was, he asked us pretty simply, when you have a case like this in front of you, will you make a smear? And I just looked at it and I said, no, I'll not make a smear. And then he gave me another case where he showed me a picture like this and he says, will you now make a smear? I said, yes, of course, I'll make a smear. He says, so how will you decide whether you will make a smear or you will not make a smear? And that, actually gave us the concept of what is called slide review rules and slide review criteria, which a laboratory needs to define depending upon the flagging criteria that they have in their respective hematology analyzers. So this gets us to a pertinent question as to how does one decide to review or not to review a slide. So there are rules, which define as to how you will go ahead and make a smear or not to make a smear. And depending upon the flagging criteria which you got from your hematology analyzer, where you had definitive flags and the suspect flags, you define the criteria as to when you will make a smear or when you will not make a smear. And this is what is called the slide review rules. So let's take a quick question regarding slide review rules. There are four choices here. They are supposedly 41 in number. They need to be defined by the user and validated. They need to be defined by the vendor, or they are defined by the hematology consortium. And the answer to this is B, which is need to be defined by the user and validated before they are put into effect in your respective laboratories. So what are the governing criteria to define your rules? Obviously, there are a lot of things which we need to keep in mind. The important points are, first, how much is the workload or the burden that you need to take care of in terms of the number of slides that you want to review? What will be the cost which will be involved in identifying, or defining that how many slides you will actually review? Then what is your turnaround time? And again, as I said, validating those rules to define whether you are precise and accurate at the same time. So let me take an example from my own laboratory. When we talk about NABL, what does NABL tell us with regard to workload and how does it define various laboratories? For example, small to medium-sized laboratories are classified as the ones which have less than 100 samples a day or maybe less than 400 samples a day. And large laboratories are the ones which have more than say 100 CBC samples, more than 400 samples a day as a lab. And even if they're running 24/7, they're again, kind of laboratories which are large sized labs. Now, if you look at our hospital, we have about 400 odd samples of CBC, somewhere around 450 to 500 today in 24 hours. And in addition to all this, we don't not only do CBC, we do a lot of other tests, for example, hemostasis testing, for example, flow cytometry, bone marrow examinations, protein electrophoresis, just to name a few. And how many people are actually available to really report the slides out? You have two authorized, in fact, four signatories which are there in the laboratory, out of which one is me and three others. Obviously, my contributions are relatively limited considering that I also have significant amount of administrative workload. So obviously, when you're looking at all of this work which is coming inside the laboratory, three people handling the workload and have to take care of it for the next 24 hours. So in a typical day at our hospital, we have roughly about 400 patient profiles, especially with respect to CBC, slightly more than that today, per 24 hours, at a time when there are phones ringing and clinicians are wanting the results to come quickly. They also want to at times have a look at the smear along with us, not only for the peripheral smears, but the bone marrow. When you want to do all this, you are expected to make sure that you're not just taking on the burden of working alone. So just like any other laboratory, this leads us to a concept wherein we want to define the rules. How do we want to define the rules? We want to define them in the context of normal ranges. We want to identify the critical values where we need to inform the clinical colleagues of a potential case where they need to intervene quickly. We want to look at the delta checks. We also look at relative, kind of relationships. For example, there is a rule of three which is used for RBCs, hemoglobin, and hematocrit. There might be times when we might be crossing the linearity and we would want to do what is called the dilution or do it manually. And of course, how the pathologist will eventually review, my other colleagues would also sit down and review. All this needs to be defined, keeping in mind the workloads or the stats which are coming in front of you. So how does one know the rules? In fact, this was a question which was asked during our assessment by the assessor. And most of the times people would say procedure manuals, but in reality, what does one come across? One comes across the fact that a lot of people just actually claim that most of the rules that they do is like in their memory, and sometimes others might be saying that it's posted on the instruments, cabinets, or countertops. But in all practical reality, the fact of the matter is rules will either need to be defined in within the instrument itself, which will help you to do automated slide making and staining, and it will also help you to ensure that you are doing the right information, taking the right information to reduce the burden at your laboratories. So now let us look at the slide review rate. If we had 100% slide review rate in our laboratory, we have roughly about 400 CBC samples. That means 400 CBC smears that to be made. We have four signatories, 8 man hours for each signatory. So that means we have roughly about 32 hours for us to really look at the smears. And let's say if we take the ideal, smear time of 10 minutes for every case, we need 4,000 minutes. That's about 67 hours. But we had only 32. What does this mean? We have a deficit of 35 man hours. Now, let's say if we take a slide review rate of 30%, that means we need to review 120 smears. And for those 120 smears, we need 1200 minutes, which makes it, about 20 hours. Now, this is very much possible. So therefore, getting the slide review to a reasonable rate becomes extremely important. I'm not advocating 30% as the slide review rate, but keeping these calculations in mind, a 30% or a lower rate is a reasonable one for us to work on. And we must also keep in mind that when you do a manual review of validity, there will be a lot of individual decisions, there will be a lot of variability between the individuals. And of course, the individual performance becomes extremely important compared to, for example, an automated review. There's also a significant amount of variance factor. And as I told you, inter-individual inconsistencies will also mar the entire work that's being done. So what's the solution to obviating the issues of manual review? Can we have something called automated decision rules or automated review? We could also use the concept of what is called auto verification. We'll talk about it a little later. We could also talk about something like automated reflex testing. For example, there's sometimes you might want to just go ahead and do reflex testing for alternate, or the test which might give you alternate diagnosis. And most importantly, the decision rules which we'll define should preferably be aligned with the laboratory information system or a good middleware so that you're able to eventually get out good quality out of it and have the cost benefit as well. In any good laboratory, the validation or the verification or the authorization process, what do? You generally review the QC results, you review your analyzer performance, maybe perform a delta check to the known values of the previous samples, and of course ensure that there were no problems with respect to drawing the sample from the right vein, from the right person at the right time, and also ensuring complete integrity of the sample, and then compare the previously related results and give the final result process. Now, if all this needs to be done manually, you will need to have adequate time, and you cannot therefore release say 400 smear results, or look at 400 smears and then release these kind of results from a laboratory. So after a classical automated complete blood counting and the differential results that have been produced, what do? We generally verify a report. We might again do a dilution on the same or the other analyzer. We might examine a smear, maybe do differential counting, or go ahead with maybe alternate testing that might be required. So the principles of review are: we want to reduce the number of samples requiring review to the greatest possible extent. We want the analyzers to be fast with as low a cost per test as possible. We know humans are smart, but we are slow. There are high labor costs, especially in Western nations, and good ones are becoming harder to find. Even for that matter, making sure that our colleagues are able to pick up, the abnormalities easily. Uh, Analyzer is something which actually helps you. And of course, analyzer false positives may work a little more, and false negatives obviously will harm the patient. So therefore, you have to create a balance between everything to ensure that whatever is being done is good for the patient. Therefore, for a typical review of a slide, we need to keep in mind as to the safety of the patient, what is very safe for the patient, what is most effective, ensuring that we're not unnecessarily having too many false positives. How do we know is by ensuring that we are going to be validating it and experiencing within the lab. Is that enough, or maybe we should have some references to it as well? So the first, practical discourse regarding the slide review criteria was initiated initially by International Society of Laboratory Hematology nearly about 2 decades ago. And the inspiration for this was Sir Bernard Human, who actually ensured that this part of it is actually taken care of by going ahead and doing activity which will give us information to practice the slide reviews. So these were the various rules which were defined across by a set of hematopathologists by for ISLH and eventually even published. So the aim was to set specific functional guidelines, and this in turn should be actually aiding the laboratories to reduce the number of hematology result reviews. And at the same time, they wanted to ensure that there is no significant loss of useful clinical data and there's no harm done to the patient at the same time. There were a lot of people who participated, unfortunately, none from India in this particular activity. Most of the ones were either from Europe or from America and Canada. Of course, Australia was also a party to it. And they said, there were 2 days of, significant deliberations. Nearly 20 hematologists, hematopathologists actually sat across to decide as to what the number of rules could be. And it is mentioned in this very interesting slide review from Elkin Simpson, where it says nearly 200 sodas, teas, and coffees were actually consumed. And finally, they come out with 2,000 rules. 2,000 rules, for God's sake. And this eventually was cut down significantly, and finally this publication came about, which is the International Consensus Group for Hematology Review, which gave us the suggested criteria for automated CBC and WBC differentials. And interestingly, in this, finally, the number of rules was only 41. So what they followed was 1,000 patient specimens from daily workload over several days, and approximately 200 specimens which had results the previous day, for the delta results. All the results were analyzed for flags, vote outs, etc. And they compared each lab's rules to consensus rules and compared the efficacy of individual consensus rules, for going ahead and working on this. These were the four sets of company analyzers which were used in this case. You had Advia 120, Celldyne from Abbott, Jennison 750 from Beckman Coulter, and SE 9000 XE 2100 from Sysmex. And these were the four sets of companies whose instruments were used in this study. And definitive positive smear findings include the morphological findings of RBCs, the platelets, toxic changes, Dole bodies, or any malarial parasite. And of course, the abnormal cell types like blasts, petamyelocytes, myelocytes, etc. And out of all the parameters, the rules finally were within these five categories. You got the WBC parameter rules, the platelet parameter rules, RBC hemoglobin parameter, differential parameters, and of course the suspect codes and flags, including the neonates and the first time samples, which were looked into. A total of 41 consensus rules, as I just mentioned, was something that the group came about after doing deliberations for over 2 days. So these were some of the consensus rules for WBCs in terms of counts, more than 4,000, less than 11,000 for the first time. You would do a slide review. For example, if we had WBCs of less than 4,000 first time and no flags, you will still do a slide review and stuff like that. All these were the different rules which were there for WBCs. Again, for the neutrophils, the counts in terms of absolute counting, again, you would want to do a slide review. You had some flags for immature granulocytes, NRBCs of blasts, or atypical limbs where you will do a slide review. Similarly, for platelets, less than 100 for the first time, a slide review, and many others which have been, kind of put across here in this particular slide. Again, for red blood cells, you were looking at the mean corpus follicular volume, the red cell distribution width, and of course the fragment flags, and a hemoglobin of 7 as a cutoff. Again, the rules were defined where you will verify and where you will review. Uh, so based on that, we took those rules as a primary set of rules in our center, and we also defined the rules which we could do in our center. And as you see, of course, a smart fellow like me and my team needed to be there to ensure that we are doing this activity together. And finally, we came up, we did this activity over a period of 15 days. In fact, it was done as a part of NABL, kind of NC closure activity, wherein we looked at the workloads that we had, from day one. And as you can see, the number of samples was much higher on Mondays. And as we fagged out towards the weekend, the numbers went down. And again, it would go up the next Monday. And from these samples, we made all the smears. And eventually, once we made the smears, we came up with the number of rules. The number of rules which we got in our laboratory at that point of time was 64. And with those rules, we tried and validated it and saw using what is called the truth table. You defined whether the sample was, we had a rule which was triggered. We had a positive finding, that means it was true positive. There was a rule which was triggered, but there was no finding on the smear. It was false positive. Not triggered any rule, but we found a finding on the smear that was false negative. Similarly, not triggered, and no positive finding, obviously a true negative. So you were looking at true positives, true negatives, false positives, and false negatives to identify what would give you a reasonable sensitivity. Now, this is the data which we got for true positives and true negatives for our cases. And when we look at the false negatives, we don't want to miss any case, were less than 2%. In fact, globally, most of the labs, have it somewhere around less than 5%. But fortunately for us, it was 1.78%. So this is how the entire activity is done for defining your slide review rules and identifying them and eventually validating them in your own laboratory. So this was the data. As you can see, the total number of cases that we evaluated was nearly about 7,600 cases, and we had a false negative rate of 1.79. We also had false positives about 2.61. That means our burden of false positive was not that bad, and that gave us a reasonably good, kind of comfort in dealing with our case. So what was the reason for false negative? We analyzed the data and we realized that, majority of our cases, we had ignored the false negative analysis, either by if the flagging criteria or the delta check was primarily ignored, either by the technical staff or by the doctors. And of course, we also had mild shift, which was ignored. You had some reactive lymphoid cells, which again was ignored, some platelet anisocytosis, etc. All these were the causes for false negative results. And if you look at the false positive rate analysis that we had in our case, it was primarily due to suspect flags, and obviously that meant that we needed to realign our, the flagging thresholds which we had set up in our analyzer. Thus, if I have to give you a take-home message from this entire activity of slide review rules, the flagging criteria, etc., what am I trying to tell you? I'm trying to tell you for optimal use of resources, we need to first of all acknowledge that this is something that we need to do in our respective laboratories. We need to define the criteria for the slide review, in our respective labs. We need to validate these rules by doing the activity which I just showed you in the last few slides. We need to train our staff to ensure that they are looking into the activity of doing this work, and we also need to implement it eventually. And once we have done this, we need to make sure that we are revisiting and reviewing it at least once a year to ensure that the false negative rate is as low as less than 5%, and update any changes in such a review. And also preferably use laboratory information system along with middle layer to make automated slide making possible. Now, this would mean that, I have come to the end of my presentation. However, as they say, picture to abhi baki hai mere dost. I would want you to go through the next concept which needs to be kept in mind, and that's about auto validation. In fact, interestingly, this is something which is even allowed internationally by the standard, which is the usual standard that most of us follow. That is 15189. The standard current version is 2022, and even in that version, the standard says very clearly that you can have what is called automated selection and release or reporting of results. Now, that gets us to the poll question. Auto verification of the sample reports needs a defined verification on the laboratory information system. Reports need to have signatures of the person who defines that engine. It usually allows to follow us to a certain guideline called CSLI guideline, what is called Auto 10. And the answer to this question is actually all of the above, because all of these are required to ensure that auto verification of the results can happen. Now, this is the CLSI guideline, which is the Auto 10 guideline approved by the uh, Clinical Laboratory Standardization Institute. And as per this, you are able to define your entire activity of setting up the auto verification engine. When we set up our auto verification processes, we need to get a few things straight. First of all, we need to identify what are our expectations. What are we really trying to get out of the auto verification engine? And also ensuring that we're actually kind of tuned to it rather than trying to do something too quickly. We also need to adapt to the change. There'll be some degree of comfort zones which will be kind of shaken when you're trying to get into an automated selection and release of reports. And more important than any of these, are you actually ready? Is your laboratory information system or the middleware system actually going to let you do this, or is that going to be a showstopper? So as they say, whenever you're trying to do anything which is going to be changing what was happening previously, there are lots of stages which everybody goes through. The initial stage of shock and denial. Obviously, you get angry as to why do you want to change at all. You try to negotiate and get some things and maybe leave some things out. May get into a state of depression at point of time. But however, at some point of time, you will eventually test it out and test the waters to see as to how it pans out. And once you start getting a positive vibe out of it, you start accepting. And this is very much the status, not only in real life, but also in adapting to the changes in the auto verification process that you're going to be adopting in your laboratory. This concept obviously is no different. You do what is called the PDCA concept, which is the plan, do, check, and act cycle, and you keep doing it. But to do that, you first need to define what is called the auto verification engine. This auto verification engine actually needs to be defined by the laboratory personnel who are actually going to be letting a lot of results pass through the auto verification process. So you need to have what is called the pre-analytical information, for example, regarding the patient, regarding from which area the sample is coming from, for example, gastroenterology or nephrology. Similarly, analytical information from the analyzer regarding the data which is coming out, including some graphic information which might be required. And then once that is happening, you might need to now define in your post-analytical process whether you will want a manually intervention done for you to release the reports, or the results will get auto-verified. All this process actually needs to define, when you're defining your auto verification engine, you need to not only set up the engine, you need to again, kind of validate the whole process. And once you've validated the whole process, does the auto verification engine come into picture? So classically, what happens, a clinical laboratory reporting system, you have what is called the analytical phase, which most of us are mainly interested in. You have a biological plausibility by an automated expert system, which usually involves the middleware. If there is it is kind of acceptable to that, then you will just validate the report immediately. However, if that's not kind of acceptable, it'll go through the reevaluation process and maybe through alternate methodologies, or at times it may even go to the laboratory physician's desk and finally eventually get into what is called the release and release of reports by an automated system. So finally, the take-home message, auto-verification or validation is possible with modern analyzers. It will help you to ensure that your productivity goes up, you reduce your turnaround times, and your manual reviews go down significantly. It can also help you to set up a paperless environment in your laboratory, and additionally add to the capacity of your laboratory without adding further staff. It also helps you to reduce or optimize, the possibilities of error which would have happened otherwise, and more importantly, a standardized approach to the data flow, which helps one to get the best possible results for our patient. With that, I would like to thank you all for your kind attention, and I'll be happy to take questions if there are any. I would also like to show you the bibliography that I have used for my presentation. This is the bibliography that I've used for my presentation, and I'd be happy to take questions if there are any. Thank you very much for your kind attention once again.
With this, we end the talk, and I would like to share this QR code for people who want to join the Telegram group. As someone posted in the chat box, they were wanting to get into the group. So this is the QR code. You can scan it and you will be redirected to join the group. I request all participants to post their queries, if any. I would like to also invite Dr. Kunal to give his comments.
Hi, Diksha. Thank
Hi,
you.
sir.
It was a wonderful talk by Dr. Anil on a very, very, very important topic in day-to-day practice. For students who are not used to these slide divider criteria, who have not done this in your day-to-day practice yet, I would request that, every lab has a CPC, go back to your cell counter, check. There are different things which are there maybe around in your counter. So I would request you to check what are the kind of flags. Dr. Anil started his talk with the slide that get used to your cell counter, the asterisk marks, the plus marks, the minus marks. That is number one. You should know in your cell counter what does those remarks or those alphabet mean. Number two, you will, in many labs, you might see a printout next to the cell counter, which is made for the technologist, especially in NABL or CAP accredited labs, which says these are slide review criteria, or which says make a slide because of this criteria, or this has been taught to the technologist. Ask them, how do you decide when a slide is to be made? Okay, is the slide to be made in most labs currently? It's a completely normal unflagged sample, which the machine sometimes labels as negative or no flag. Everything is normal looking. Generally, people may not make a slide on a 5-part counter. So you ask your technologist or senior, on what basis do you make a slide? Okay, there might be one criteria, 10, 20, 30 criteria. Now, everybody knows low platelet, you have to make a slide. But if the hemoglobin is 11, do I make a slide? Okay, the question is hemoglobin is 11 for which age? So you need to make it age dependent. So this is what you need to know. Then you ask your consultants or your doctors or the lab team again, have we added customized rules flags or Q flags or Q values or any such things Dr. Anand was mentioning into the algorithm of the machine? Or are there any such flags into the algorithm of the lab software which you have? Okay, are we using any? You should generally have a list, and most of the accredited labs or even the unaccredited labs or in general good quality labs will have a list of these flags or slide reviews. Okay, so one should know and understand it. Dr. Anil rightly pointed out, it's just not that I copy pasted the rule from my friend or it was given by the company. We, as a laboratory, need to have uniform rules. We need to validate those rules, and he showed it beautifully with the positive, negative, true test value. One thing I would also recommend is for people who are practicing or who will go into practice, or you will now become in charge of a lab where you have a CBC machine. Now, a very simple flag, for example, that plus sign means some value is increased. Okay, and I'll again come to plate, say, or minus sign will say some value is decreased. Now, if I say hemoglobin 12, okay, for male it is decreased, for female it is normal. So one, it is gender specific. Two, hemoglobin is age specific. What happens is most of the companies, when they install cell counter, they would have added only one reference range. Okay, for a particular age, it may not be appropriate for a child, pediatric sample, or something. So every time you see 45% lymphocytes, are you going to make a slide? If it's a pediatric normal child, that is normal for that child. So you are going to increase your workload only because you did not look at how the company person had inserted those rules. And most of the analyzers today allow you to change these rules or add to those rules. So you should ask what is the reference of these rules. Something like a basic textbook, like a DESI textbook of hematology, you can use the criteria mentioned there, age specific, and most analyzers today allow you to put age and sex specific normal ranges within your machine. What this does is use the same normal range which your software or lab typing software is using, where you're going to issue reports. Use the same range into your machine. We see this discrepancy very often. It shows plus or minus on the CBC machine, but in the lab software it becomes normal. So people reviewing the data on the machine do not have the idea of what is happening. So this is something very, very basic. We always inform that during the time of installation or later, when you identify the reference ranges are not similar in your lab software and machine, please get that done. That's going to be the first starting tool to identify. What Dr. Anil showed were the basic sort of plus and minus flagging rules given by the company. Then you gave you examples of, for example, a quantitative flag, uh, say a Q flag, which is there in some of the Sysmex companies. For example, we worked on a flag called IRBC flag, which shows malaria. Okay. Now, the cutoff of that flag given by the company is 100. Okay. That is the cutoff based on the algorithm that they have used. It does not mean when it is 80, it will not be malaria. So we validated that study, we used that study, and we saw in majority cases above 40, you could still see malaria. So in our lab, we have validated that flag, and above 40, irrespective whether the machine flags it or not, we look for malaria whether the patient is asked or not. So we have modified a quantitative flag based on our study. But we know less than 40, 30, 20, 10 value for the IRBC flag is insignificant. Okay. Now you see an example, the moment you get a flag by the company's flag called atypical lymphocyte, we are immediately worried there is an atypical lymphocyte. Now, this atypical starts going into our peripheral smear report. Understand what does this atypical mean? You see a pediatric sample, most pediatric samples get labeled normal lymphocyte, atypical lymphocyte. For the machine, something different from normal, the terminology uses atypical. It does not mean blast. It does not mean activated. It does not mean abnormal. Machine does not know. That is what the terminology used by the company. And we start putting atypical into our reports and then we start doubting it. Okay. For example, there was a flag on MCH, only low MCH. Okay, it used to give MCH minus. In my previous place of work, that was the flag for reading the slide. But what we identified, a borderline low MCH, when there is no flagging for any other parameter, neither hemoglobin, neither MCV, neither MCHC, neither any other RBC parameter, WBC platelet being normal, we validated with 100 cases. We said this flag is of no use when it comes alone, independent of other flags. I will not make a slide. Okay, so we stopped using that flag. Now, similarly, you can use combination of flags. One can use certain combination of flags, say, okay, this plus this flag, I am suspecting iron deficiency. Simple thing. A low MCV, a low MCH, a high RDW. you are going to suspect iron deficiency anemia based on the algorithm. So you can make those kind of things. Then comes customized rules or comment rules. What we have done in our lab is to train our technologist. We no longer have any paper stuck out next to the machine, because modern day analyzers allow you to put all your flags and all your rules into the machine. We have added them as formulas or rules into the machine. As simple thing like MCV is 70. Okay, the counter will give minus. You may or may not read, but we put a comment there which comes automatically for the technician. A review slide for low MCV. Now, this comment is understood very beautifully by the technologist. This is what I have to do. Or there will be a flag, review slide for low MCV, review slide for low MCH, review slide for high RDW. Now they are going back to the values, reading those values. I didn't do anything extra. I just put if MCV less than 80, show comment, following comment. If MCH less than say 27, or say certain level, show following comment. Okay. So when the platelets are minus, we say review slide for low platelets. Then we can put formulas like hemoglobin hematocrit mismatch. Some counters have the same name. Some counters have a flag called increased turbidity, which technicians miss. Some counters, when there is an erroneous, say for example, a lot of clumping, okay, the hemoglobin is very, very low, it shows error, but it does not highlight what error it is. So if the hemoglobin hematocrit is mismatched, we write rule of three violated, hemoglobin hematocrit mismatch, look for clumping on smear. Something like this based on, so the technologist or the doctor who is reading that CBC can absorb that comment, can learn from it also simultaneously. Because if you put 25 comments onto the next of a CBC, it's impossible for a fresh technologist, even with for experienced technologist, to review each and every comment. Say you say hemoglobin less than 8, make a slide. WBC more than 20,000, less than 4,000, make a slide. Platelet less than 1.5 like make a slide. Low MCV, make a slide. How many rules is the staff going to remember? Or the doctor going to remember? This way, when you use automation to its fulfillment, you can understand why you have made those slides. Again, these are just broad ideas and examples I've given you. Dr. Anil highlighted the different examples. At the end of it, you need to validate. You need to make a summary of these rules and flags. You need to validate in your lab. And I still remember in my early days at my previous place of work, Dr. Anil Handu himself was our inspector, and we got a non-conformance, a beautiful non-conformance, which said you have slide review rules, but you never validated them. So we did the same study with Dr. Anil showed you, where we took for the next 3 consecutive days all CBC sample slides were made. 2 pathologists independently saw all the slides, and we did the same truth table with Dr. Anil showed you, and we verified each and every flag. That is where we learned some flags were not required, some were not useful, some were extremely useful. Yeah. So these kind of things or exercises done in a lab will help everyone in the lab learn a lot. And that's it from me, sort of a broad summary on what Dr. Anil spoke. And if there are any questions, I'm happy to take him those questions on your behalf.
Thank you, sir. It seems the audience has liked the class and has no comments or
No comments.
questions for us to
There are no
answer or ask.
Sometimes this can be a challenging talk because not everyone has had hands-on experience. But if anyone of Diksha, for example, would like to add, suggest something, Dr. Priya, if you want to add based on your experience, please share the same with the students.
Sir, I would like to, for the benefit of the listeners, I would like to put
Sure.
forth my query. Like Sir had mentioned in his talk a number of times about middleware. So
Yes.
I hope many of the listeners know about it, but if you don't know about it, can you just clarify the concept of middleware?
So middleware is like a software which is the one which is interacting. Now there can be two types of the middlewares. One is which is inserted into the lab software, and sometimes some companies have a middleware which works between the machine as well as your software. So there is a program through which the data is run through, and that program can generate some flags. For example, uh, nowadays the machines themselves can do it, or your lab software can do it. I'll give you an example. ICU sample is coming. Today the hemoglobin is 13. Tomorrow the hemoglobin is 11 or 10. Okay. There's a value called a delta check. This is what the middleware, the lab software can pick up. Nowadays the machines can pick up. However, what happens is most machines is that every sample has a unique accession code. That is a barcode number which the machine see. So they do not, sometimes are not able to identify that this is the same Amit Sharma's sample which came yesterday, and this is the same Amit Sharma which has come today, because they have two different access codes. However, if the middleware or the lab software has the name of the patient, has, they say, the hospital ID of the patient, when the data goes to that middleware or the software, it generates and says hemoglobin was 10 yesterday, today it is, or it was 13 yesterday, today is 10. And as a lab director or consultant, I can set in some rules. I can say delta or a difference for allowable hemoglobin. One day maximum 0.5 to 1, maybe IC samples, hospitals will be 1, some transfusion, more than 1, challenging. Okay, I can say for platelets put a cutoff of 20%, for example. Okay, today the platelet is 50,000, but yesterday it was 2 lakhs. Either there are clumps, there's sudden drastic fall in the same patient. So this kind of activity, like an example is delta check, there could be more other things. You can process the graphical data of the software. You can, nowadays there is potential for using AI-based algorithms which the softwares can do. So there is this, it's a kind of a software interlinking your machine and your uh, actual lab software, which can help you add more value to your patient's data. That's what I understand in terms of day-to-day practice.
So is it necessary to have a middleware for auto verification of reports, or one can do without it?
There are some new rules coming in. Actually, Dr. Anu would have been the best person, because I'm also unclear about having a middleware for this. But I also understand some companies say it is required, but I am unsure of what added value it will have if either your machine or your software is having some feature to cross verify those things. Okay, so as long as I have added all rules into my machine and or my software, and I can check or double check that everything is clear. And again, before I apply auto verification, I have to take 300 normal, 500 normal, or 2-3 days or 1 week of normal data, run it, and say this is the sample I would have auto verified. Is there a problem? Would I have missed something basis of this? So that verification happens. When it is a lab software based, the challenge with lab softwares can be they are updated many times. One file gets updated. What if those verification software goes away? So that is where having a third party middleware in between may have added value. But actual NABL current rules, I am not very fully aware. But yeah, it would be an edit feature, but I am not sure it is really always required.
Mandatory search. Yes. Thank you, sir. We have one question. Priya, go ahead.
Sir, we have one question. Dr. Sanchit Jain has asked, how much variation from counters value can manual platelet vary in case of giant platelets?
So this is related to my recent previous talk on platelet counts, a 1 hour session. You'll have to go through it again. So basically, again, I'll emphasize in short, manual platelet count ideally is a Newbar chamber count, but what is done in practice is peripheral smear. Peripheral smear platelet, I don't call it a count, I call it a peripheral smear platelet estimate. In presence of clumps, no count is correct. Once you have a peripheral smear platelet estimate, for example, in our lab, we use the criteria of multiplying it by 10,000 to give an estimate to assess in a well spread area. Now, in some lab, they're applying 15,000, that's your variation. Okay, 10 platelets, I'll give 1 lakh, you'll give 1,50,000. The way I use it is, how did I reach 10,000? While at Tata Hospital doing our senior agency, me and my colleague Prashant actually did a study. We actually took 200, 300 samples. We actually sat and said, this is the smear evaluation. 2 people used different multiplication factors, 10, 15, 20, and validated with the counter count for low, normal, high. And then we realized in our microscope, in our hand with 2 doctors, we are reaching 10,000. And there is reference to literature. Okay. So I personally believe 10,000 is there, but understand at very low levels, below 50,000, below 20,000, and at very high levels, say above 3 lakhs, 4 lakhs, these are not accurate. This is just a rough estimate. Okay. And that is where your logic comes. I do not like changing my counter counts given by the counter based on my manual estimate unless there is a major reason to do so. Obviously, one is clumps, then I don't give any counts. Okay, I'll say it is more than the above reported counter count or cannot be accurately identified. If it is EDTA into pseudothrombocytopenia, I may add accurate. Second is when there's a rare case where the whole platelet impedance histogram is gone awry and you can make out that this histogram is wrong. You then generally rely on an alternate method. I would prefer the optical platelet count or a fluorescent count or an alternate method, but not always the peripheral smear count. So these are the few things. So how much variation is first there is too much variation in manually estimating platelet count. And generally that is far higher than the machine. And you take 3 doctors in the same lab, every day they are giving 3 different counts. And that's why doctors get worried about, So I don't like this question when a surgeon says, give me manual platelet count, I have a surgery tomorrow. So I simply give the machine count and say this has been verified manually on the peripheral smear. And that's what we put our comment. I hope that clarifies your question, Dr. Sanjay.
Sir, there are no more questions, and thank you so much for your valuable comments. What I would like to add few
Sure.
suggestions to residents who are listening. So please make it a point. At least you see some slides where you see the flags, whatever slides you're seeing. Because what residents do is the slides come, they just see the slides and report it off and finish it off. Please try to go back and see. At least for the bone marrow aspirates, you get the counter values, at least see those flags. And also please go to your lab and see what is the slide review criteria you're following in your labs.
Yeah, I would like to add, it's a crime to see a slide without seeing your graph and CBC printout or photo. So please do not do it for any case. I would rather have it that you saw the CBC histogram in the graph and didn't see the slide is better off. Because I would say you could do a better job by seeing that, because half-hearted seeing the slide is of no value. So I would suggest do it always for every CBC. If you're seeing the slide, means there is some reason the slide has been made. You need to know that. Your staff needs to know that. So it's not only training the pathologist, it's the CBC machine staff should know why the slide was made. In our lab, it is a rule when they send a slide, they put a small comment on the sticker, on the slide, or on the paper. Low HB, they put an arrow HB low, platelet low. 1 or 2 things they'll write, or they'll send a printout to us. This is the reason why the slide has been made. This gives us the confidence that they know why the slide has been made. So the journey starts from there, and I would encourage all pathologists have to see CBC, the values, histograms, and flags without fail.
Okay, sir. Thank you so much.
Thank you.
There are no questions. And so with this, we'll end the session then.